Hi everyone, our subject today is red eye in pediatric. The age of onset of the red eye, the nature of the discharge, and the associated sign and symptom are the most important component of the history. History of exposure to irritant, allergy, chemical and other, and of trauma or infectious contact, pink eye in a school or daycare setting may also be helpful for infant inquire about possibility of any maternal infection. How to approach to a baby with red eye after performing history and physical examination. Is there conjunctival injection in a neonate below 30 days of age? Is there any eye discharge present? If yes, consider a gram stain and culture, chlamydia culture, a nucleic acid amplification test, PCR culture, culture for herpes if vesicle is present. This is maybe bacterial conjunctivitis, sexual transmitted disease, viral conjunctivitis, or dacryostenosis. If there is no eye discharge in a neonate, this is maybe glaucoma, viral conjunctivitis, chemical conjunctivitis, corneal abrasion, subconjunctival hemorrhage. If the conjunctival injection more than 1 month of age, is there any eye discharge present? In this case, look for allergic symptom associated like tearing, eye rubbing. If it is present, this is maybe allergic conjunctivitis, limbal vernal conjunctivitis. If there is no allergic symptom, this is maybe viral conjunctivitis, bacterial conjunctivitis, STD, gonorrhea, and chlamydia. If there is no eye discharge in patient more than 1 month of age, is there history of trauma, foreign body, chemical exposure, or irritation? In this case, consider fluorescein stain and inspection with wood lamps or a slit lamp. This is maybe chemical conjunctivitis, corneal abrasion, foreign body, irritation, dry eyes, subconjunctival hemorrhage. If there is painful red eye, abnormal vision with or without photophobia, with or without lacrimation, this may include glaucoma, keratitis, endophthalmitis, iritis, iridocyclitis, scleritis, Stevens-Johnson syndrome, and infection with Bartonella hensel. If there is no eye discharge with eyelid redness, irritation, this is maybe blepharoconjunctivitis, herpes simplex virus, molluscum contagiosum, and pubic lice. In the history and physical examination, if there is periorbital redness and or swelling, is there proptosis, ophthalmoplegia, vision abnormality? In this case, patient needs CT. This is maybe orbital cellulitis or orbital tumor. If there is no ophthalmoplegia or proptosis or vision abnormality, this is maybe preseptal orbital cellulitis, allergic reaction, angioneurotic response, insect bite, sting, chalazion, hordeum, dacryocystitis, dacryoadenitis, ecchymosis, trauma, vascular lesion, hemangioma, nevus flammis, or Sturge-Weber syndrome. Recommended investigation, usually not necessarily, as conjunctivitis is common and harmless. Full blood count, leukocytosis for bacterial infection, ANA and rheumatoid factor for children with rheumatoid arthritis, swab for purulent and severe discharge to exclude chlamydia or gonococcal infection, MRI for any tumor such as rhabdomyosarcoma, tonometry to measure eye pressure for suspected glaucoma. Top tips: episcleral and retinal hemorrhage in neonate are common after vaginal delivery. Although these seem alarming to parents and clinicians, they are harmless and disappear within 2 weeks. Ophthalmia neonatorum refer to inflammation of the conjunctiva within the first month of life, once principally caused by gonococcal infection. The most common causes are now chlamydia, staphylococci, chemical conjunctivitis caused by topical antimicrobial agent, which is silver nitrate. The silver nitrate reduced the incidence of gonococcal ophthalmia from 10% to 0.3%. At birth, the nasolacrimal duct is often blocked, and the diagnosis is made by history or flexing discharge with the pressure over the lacrimal sac. This resolves spontaneously in more than 95% over a few months, rarely delayed until the age of 1 year, and rarely need surgery. Gonococcal conjunctivitis present in first few days of life with a rapidly progressive profuse purulent discharge. The cornea is rapidly affected. Urgent treatment with antibiotic is needed. Measurement of visual acuity is needed for keratitis, not for conjunctivitis. Uveitis present with the pain, lacrimation, photophobia, and conjunctival hyperemia. It occurs mainly in children with the monoarticular or pauci-articular form of rheumatoid arthritis. Children with the glaucoma usually present with the corneal irritation, tearing, photophobia, conjunctival injection, and visual impairment. The most important sign is corneal enlargement. Systemic disease associated with conjunctivitis include Kawasaki disease, Stevens-Johnson syndrome, and Lyme disease. They are characterized by greater bulbar than palpebral involvement and no eye discharge. In contrast, infectious conjunctivitis has more palpebral involvement. Red flag. Conjunctivitis in a neonate may be caused by sexual transmitted disease acquired during vaginal delivery. Ensure you do not miss chlamydia or gonococcal infection. Ophthalmia neonatorum is a potentially blinding disease. It needs urgent diagnosis. Chlamydia is the most common cause of bacterial neonatal conjunctivitis in England, although it often harmless. 10% to 20% of infants experience chlamydial pneumonia, which is a serious disease. Therefore, infants should receive topical as well as systemic antibiotic. Bilateral redness of the eyes may suggest viral or allergic conjunctivitis, while unilateral redness often suggests foreign body, which can be detected in everting the upper lid to check for concealed foreign body. Pain is not usually caused by conjunctivitis, but rather by uveitis, keratitis, glaucoma, or scleritis. Epidemic keratoconjunctivitis is highly infectious, caused by adenovirus type 8. Hygienic measures like hand washing are essential to prevent spread of the disease. A child with red eye and impaired vision is unlikely to have conjunctivitis. Keratitis is more likely. Ask whether there is a gritty sensation, which often occur with keratitis. Steroid should never be prescribed for red eyes unless herpes infection is excluded. If diagnosis is not clear, a referral to an ophthalmologist is indicated. Orbital cellulitis present as a red and swollen eye and must be differentiated from rhabdomyosarcoma, which is very aggressive malignancy of the embryonic muscle tissue within the orbit. The tumor is often curable with the radiation and radiotherapy. Thank you for your listening.